So we're going to begin with Dr. Karen Winkfield. Dr. Winkfield is the Executive Director of the Meharry-Vanderbilt Alliance, which is a strategic partnership between Meharry Medical College and Vanderbilt Medical Center. She is a national expert in community engagement with research focused on the design and implementation of programming to reduce sociocultural and economic barriers that contribute to disparate health outcomes for minorities and underserved populations. Dr. Winkfield.
Thank you so much, Dr. Drake. I apologize. I was on mute trying to figure out how to undo this. You'd think after all this time, we'd know how to use these Zoom functions. So first of all, I want to thank everyone for being here. I want to thank the organizers for inviting me to come and talk a little bit about patient-centered clinical trial design. This is an area of passion for me. I am a radiation oncologist and a health equity consultant that really has been focused on cancer care. But as many of you know, cancer is now a chronic illness. And so I think that there are many lessons learned from the whole design, the way that we think about cancer and cancer clinical trials that really can be applicable broadly to lots of different chronic illnesses. So again, I want to thank you all for being here, and just know that I will be kind of speaking more related to cancer, just because that's, again, where my area of expertise is. You know, when you think about clinical trials, there are so many different types of clinical trials and different ways that we have gone about designing them, whether it be observational studies or experimental studies. Are we going to be doing analytics or descriptive? I mean, we spend a lot of time thinking about the methodology and the type of clinical trial that we aim to engage in. You know, we talk a lot, and particularly around cancer, but obviously today we're talking about drug development. And so for any of these chronic illnesses, we're talking about how do we think about drugs, the development of them, and making sure that they are effective and that they have minimal toxicities. And so again, we spend a lot of time thinking about the design of these clinical trials. We also spend a lot of time thinking about regulation, data monitoring, you know, how do we make sure that the FDA is happy? What are the different types of stakeholders? Who are the gatekeepers? What is our clinical trial team going to look like? And is our institutional review board going to be happy with how we've actually outlined and delineated the trial? We have even more recently spent time talking about diversity in clinical trials. This is an area of passion for me, making sure that everyone has access to clinical trials, because we know that clinical trials are the way we move the fields forward, whether it be in cancer or arthritis. It's important to make sure that we have diverse representation in those clinical trials so that we can ensure that the medications, the discoveries, the technologies are going to be beneficial to all communities. But who are we really designing the clinical trials for? Are we designing clinical trials for companies? Are we designing them for the FDA? Are we designing them for other regulatory bodies? Are we designing them for ourselves as clinicians and researchers? My hope today is that we can actually really start to think critically about a patient-centered approach to the design and implementation of clinical trials. I think we've started to get a glimpse of how that could look in the COVID era. We've had to rethink and replan and redo a lot of the things that we've done around clinical trials to really make them more effective in this current environment. But one of the things that I still feel like we need a little bit of help with is thinking about where to insert the patient voice. When do we hear from patients about what's important to them? And how might that impact or influence the clinical trial design, the outcomes that we're actually going for? Do we wait until after the trials have been done? Do we start thinking about them right before we start thinking about post-marketing? Or do we wait until afterward? Do we not even get their voice until we try to find out after things have gone to market what their interests are? Or do we perhaps start to think about them after we've created the protocol? Well, my hope is that after today's discussion with all of my esteemed colleagues today, that we will start to think about hearing from the patients before a concept is even developed. Well, how do you go about doing that? And, it's not necessarily easy. Those of us who do community-based participatory research or any sort of community engaged research know that it can take time. But I tell you, there are ways that we can really be mindful and we can be creative in terms of how we start to hear from the patient's voice. So I wanted to share, this is a program when I was at Wake Forest. Many of you who know me understand that I just recently made a transition over to the Meharry-Vanderbilt Alliance. Previously, I was the Associate Director for Community Outreach and Engagement at the Wake Forest Comprehensive Cancer Center. And therein, we actually designed and developed a program called the Advocates for Research in Medicine. And I must say, this was a program not out of my brain, but actually one of my colleagues that I worked with who was herself a patient survivor, a cancer survivor, who said, it was really important to make sure that we're hearing from advocates and patient family members, but we know that oftentimes the language that we use, the regulations that exist, those can be foreign to many individuals. They're oftentimes foreign to us as clinicians. So imagine being a layperson and trying to get involved in cancer research. So the purpose of this program, we call it the ARM program, is to connect cancer patients and researchers to bring the patient perspective to research activities and ultimately improve outcomes. Again, which outcomes? And the outcomes indeed should be focused on the patients. And you'll find, I put a link here, the Association of Community recently asked me to patients upfront and early in the design of clinical trials. And indeed, my colleague Carla Strom, who's the one who developed the ARM program, as well as Dr. Kate Weaver, were also interviewed and gave their perspectives as well. We've taken this program, which is really around patients, caregivers, high-risk individuals, thinking about how to maintain patient-centered care and research, and allowing them to advise us. What are their voices from the cancer patients? We allow them to review the clinical trials and the proposals before they even become clinical trials. Talk about how best to implement. Are there different strategies on how to communicate with researchers? Creating that bidirectional communication, which is so vital. And then how do you disseminate the results? We actually have this program, which we've launched already. We did a pilot at Wake Forest, and now we're actually going to take it to the NCORP research base, which, as you know, the NCI is very interested in making sure that cancer research gets out into the community where the people are. And so this ARM program, which allows individuals who may have personal experience with cancer, again, as either a patient or a caregiver, they're able to represent this broad patient perspective. We are matching advocates and researchers. We do provide them with formal training. We have several different topics, as you see: cancer research, clinical trials, regulatory oversight. All of these topics are included so that the advocates can really be prepared to join in and have a say in terms of what clinical trials should look like. And indeed, aren't we indeed trying to do clinical trials to improve patient outcomes? We've got to hear from them. Now, I want to switch gears just a little bit because this is another area that we've got to work on, and it's related to cancer disparities with respect to different racial and ethnic groups. Now, again, hearing from the patients is critical. That means hearing from different communities. This snapshot was taken from the AACR's recent Cancer Progress Report that was used as a legislative briefing to really talk about the state of cancer disparities today. And while we're doing better, as you can see the curves on the right, where, yes, everyone is doing better from a cancer perspective, we see that there are still disparities that exist amongst Black men and women having the highest risk of cancer death. And again, this is about cancer. Let's talk about cardiovascular disease. Let's talk about diabetes. Let's talk about HIV/AIDS. I mean, if you look across the board, Blacks are doing worse in all of these areas. And part of the challenge is that there is underrepresentation in clinical trials. We know that. And sure, okay, people say, well, lots of folks don't participate in clinical trials. We probably only have about 8% of eligible participants who are actually engaged in clinical trials. But when you have such disparate engagement, we really need to hear from those communities and understand what some of those issues might be. And this is a prime example. Now, I'm a heme radiation oncologist. Yes, they do exist. We're a handful, but there are some of us who specialize in hematologic malignancies. And so multiple myeloma is one. where I actually end up seeing patients who are in such agony because of their disease, who come to get radiation, despite the fact that multiple myeloma is a systemic disease. Now, here's some data that was recently presented in JAMA Oncology that shows that while 20% of multiple myeloma patients are African Americans, only 5% of individuals engaged in clinical trials that were the fodder for FDA drug approval were Black. 20% of the myeloma population is Black, but only 5% represented in clinical trials. We need to do better. And so part of it is, how do we think about doing clinical trials with the patient population in mind? If we know that there's a certain population that has higher risk for or worse outcomes from a particular disease, are we really targeting them? Are we talking to them? Are we addressing that community and finding out how we can engage them in the research process early in the development of clinical trials? The last thing I want to talk about is geography. We already know geography matters. We talk a little bit about rural populations, access to clinical trials. Where are the clinical trials being done? And I keep telling my colleagues, if you keep doing the same thing, you will continue to get the same results. If you keep having clinical trials only focused in urban centers, then you're going to keep only getting urban individuals. And in fact, you might not even get urban populations because, as many of you know, there is a concentration of racial and ethnic populations in some of our urban settings, and yet they are still underrepresented in clinical trials. So access goes beyond just geography. And I think that's a really important thing to remember. Patient income level is an important thing. And so I know we're going to have some of our colleagues today who are going to talk more specifically about financial toxicity, but I wanted to point your attention to this paper that was written by my colleagues and I. It was an Esco policy statement. So the American Society for Clinical Oncology talked about addressing financial barriers to patient participation in clinical trials. And it's important. We know that there are barriers, number one, to cancer treatment in general. Cancer treatment is the number one cause of medical bankruptcy in the United States. And so if we know that, what are we doing as a community of stakeholders to address that? There are some really nice, succinct things and recommendations in this paper. So I encourage particularly some of our sponsors to take a look at this paper. Precision oncology, we know that it has such great promise, but it also has the promise of widening those gaps, those disparities, not only from a rural perspective, but also from a racial and ethnic perspective. Blacks, we know, are not being offered precision medicine at the same rates as every other group. So what are we going to do to help shape that? Well, I wanted to point your attention also to, this is some of my colleagues, my new colleagues at Vanderbilt, who have been doing these community engagement studios for a very, very long time. These are one-time facilitated consultative meetings that investigators who are interested in hearing the community voice can tap into. It's amazing. There have been lots of studios to date. They talk about precision medicine. You can actually hear from community members, panels of community members who can provide input and insight into how you are designing clinical trials. And this is available to anyone. And so I just wanted to make sure that you knew that this was aware. There's a toolkit online, so you can look up Community Engagement Studio Toolkit, and this is at the Vanderbilt Institute for Clinical and Translational Research, and that resource is available to you. So my hope, again, is that folks who are listening who are saying, well, I don't know how to get the community voice, take a look at the Community Engagement Studios and see where you might be able to make some changes, some innovative changes and strategies in terms of how to engage communities. And finally, I will point your attention to a recent paper that we just published in the Journal of Oncology Practice that actually outlines an actionable framework to address cancer care disparities. Now, again, this was done with cancer in mind, but I tell you, COVID was really made it clear that many of the things that we recommended, this actionable framework that our experts from around the country came together to discuss, many of those actionable items are broadly applicable to many chronic diseases and really should be considered. And I must say, one of the first things that came out of this work is the importance of community engagement. You have to hear from your stakeholders in order to make a difference, in order to make sure that your clinical trials are meeting the needs of the populations you're trying to serve. So with that, I'm going to close. I know we'll have some Q&A shortly, and I want to thank you so much for your attention today.